and deeper in the ear you can see the wax really embedded. You can see the mark, the indentation caused by the Q-tip, or what we call in the UK cotton bud, and it's really jarred and impacted against the patient's eardrum. So immediately I put some olive oil drops just to loosen this a bit, because it was quite stubborn and dry as well. And I managed to peel off some wax off the anterior canal wall, which is to the left. This is the patient's left ear, so the anterior canal wall, the front part of the ear canal is to the left. And I'm now just going superiorly. I want to peel this wax, and there's also a bit of keratin downwards and off the roof of the ear canal. It's really stubborn, but I'm making some headway there. And you may have noticed there's a little opening now at the top. So even at this early stage, although the ear is still really blocked, the patient did inform me that they could hear slightly better, and that's because I've broken the seal. Sometimes it's not the amount of wax, it's how the wax is located and positioned within the ear canal. You can have someone with a fully blocked ear canal right from the entrance to the eardrum, and another person with a very thin sheet of dead skin even, that's just occluding, blocking and creating an airtight seal at the entrance, and they can have similar symptoms. And just by breaking the seal, like I have already, the patient is already hearing better, but we want to get the majority and the most of this residual wax out of the ear if possible. And you may see where I am now, the ear canal kind of narrows inwards and it expands outwards. So if you look at the base of the ear canal, you can see the ear canal kind of goes in and it goes back out again. We call that region the isthmus. So everyone has a narrowing of the ear canal around 0.5 centimetre away from the eardrum, and then beyond that narrowing the ear canal widens again and it creates a recess, an inferior recess. So an inferior recess is almost like a basin at the bottom of the ear canal next to the eardrum, where we are now. And also it creates an anterior recess, so to the left-hand side of the ear canal near the eardrum. There's another cave, if you like, there, and we call that the anterior recess. So this wax has been pushed into and beyond the isthmus, and it's blocked in the inferior and anterior recesses, which makes it much more difficult to remove. I just put some more olive oil spray in. So this is special olive oil spray, not for cooking, but for safe use in the ear. In the UK, it's called ear roll. I'm sure it's available around the world, but it might have different names. And I've really soaked this, and I'm just trying to peel this slither of dead skin that's coating this wax plug, and I managed to remove that off the back part of the ear canal. And these are the procedures that, when I first started performing earwax removal many moons ago, using a different technology, a different visualization technique, I would have really struggled to even visualize the wax here, and it would have been near on impossible for me to remove safely. And that's what inspired me to develop the iClearScope, the wireless endoscope. The view with an endoscope, as you can see, it's just uncomparable. You can see the whole ear canal, the magnification's great. We can do delicate procedures off the ear canal and also off the eardrum. And some people ask me what are my favourite types of procedures. For me, it's when I'm removing stuff of the eardrum. There's just an adrenaline rush there, which I really enjoy. And just because obviously it requires a bit more skill and a steady hand as well. So you can see the majority of the eardrum, this is the in. You can see just how much of a recess there is here. The ear canal really does dip down. And the patient does mention that when they get water in the ear, which I've advised against them doing so, that the water gets trapped. And I explained it's very likely that the water gets trapped in this little basin that they've got. It's more of a prominent basin than most people would have, although we all have got a little basin there. And so the whole eardrum is visible. There's just a bit of debris you can see at the top of the ear canal near the eardrum. I've just felt comfortable removing it, so I just went with a fine-end suction probe, managed to remove that. And that's the patient's ear, so they are hearing significantly better. So that's patient 1. This is patient 2, and again you can tell similarly that it's been pushed in. You can see the mark, the indentation there. This wax, it's not as crusted, it's a bit softer, so I thought initially let me just peel it away without putting any oil in. It may come out without the assistance or need to put oil in. Now, oil's great because it does lubricate the ear, but sometimes it can blur the image, and when I first started putting oil in to the ear, I used to soak the ear for a few minutes and then get the patient to drain the ear in the opposite direction with a tissue underneath before going back in. That could be a bit laborious, and I found what's more effective is actually removing the wax whilst the oil is still in situ, so whilst it's still dosing the ear. And it requires a bit more skill because the patient's head's slightly tilted across. So me as the clinical ear care specialist, I have to be in a certain position to work on the ear. And when you've got oil in the ear and you vacuum it at the same time, it can be, you do get a bit of blurriness sometimes because as you're suctioning, you're suctioning some of the oil out of the ear, and that can cause a bit of a blur. So I'm getting better and better at it now. I've been doing it for a while, probably about the last year or so. And you can see the oil's in there. I've not drained it, and I'm going to suction it whilst the oils are there. So the first stage is to suction some of the excess oil. So at this stage, the aim is not really to remove the wax, it's just to remove some of the excess oil. And when the blurriness goes a bit, you can see I've got a bit of a wax now, and I'm just tugging away at that, and I'm just trying to loosen this off the canal wall. So whilst I'm removing some of this wax, the oil's still doing its job. It's there, it's penetrating. And what I find with the oil in situ, whilst I'm removing the wax, it helps lubricate the suction tube as well. So if the wax is a bit sticky, as the wax and oil goes up the suction tube, it lubricates the inside of the suction tube. So any wax that gets trapped will just get sucked up, which saves me removing the suction probe from the ear and pushing through a cleaning rod to unblock it. So I'm just peeling this on the bottom. There's a bit of skin here as well. And that skin, you can see it's a fresher layer there underneath the undercoat. That's fresh skin. It's very white in appearance, and as the skin oxidizes, the longer it's there, it turns into a brown and then a dark black colour almost. So that's exactly the point where the patient pushed the wax in with a cotton bud. You can see the indentation, and again I'm just lifting this off the canal wall. And similar to the last patient, this patient's got quite a prominent isthmus and narrowing, and this wax and keratin plug is lodged beyond that, and they've got a much more extreme inferior recess. So the basin, the trench that we call the inferior recess near the eardrum at the base of the ear canal, is far more prominent and significant in this patient than the first one. This patient's ear canal is also quite inclined. So everyone's ears, if you look inside someone's ears, there's a natural incline, so a very mild sloping upwards of the ear canal. This patient's probably a bit more than the norm. And I've just managed to loosen this. And this patient is a regular patient. Despite explaining to them not to use cotton buds, they guilty as charged, they admit that themselves. Coming for a few years now, and they have got a very narrow ear as well, which just makes it a bit more tricky. So I removed the majority of the plug. You've got this last piece, which is quite dry. The oil obviously hasn't penetrated this part of the wax plug. Nonetheless, I managed to remove it. You can see I'm just wriggling it through. So the patient's eardrum's in the distance. You can see the ear canal. Right at the entrance, it goes down and it goes steeply up. So I'm just trying to remove any dead skin that's in this little cave here at the entrance, because that can collect. And you can just see the eardrum there in the distance. The bottom part of the eardrum is a bit difficult to visualise, and that's because the ear canal goes up. You've got a good view there. It goes up, then it goes slightly down. Where we are at the moment, there's a little cave here. Quite often in this cave, you get a buildup of dead keratin skin, and you have to be cautious of a canal cholesteatoma or necrotizing benign osteotitis, which is where the flesh, the skin dies and the bone underneath is exposed. Typically, it can be treated with medication as opposed to surgery, where a canal cholesteatoma does need surgery. It's a lot more dangerous. So you can only see the top part of the eardrum. That's because the ear canal goes up and then it comes back down again. There's a mountain peak almost here where we are now. So I'm just using a fine end suction gauge so I can peel some of this dead skin off.